Next presenter is Dr. Shamsun Nahar.
Assalamu alaikum and good afternoon. I am Dr. Shamsun Nahar. My presenting topic is Bifurcation PCI 2-in-1. I have no financial interest, arrangements, or affiliation with any organizations. First, I would like to recapitulate some few things. Coronary bifurcation lesions accounts for 50 to 20% of all percutaneous coronary intervention. The broad anatomical, pathological spectrum of coronary bifurcation lesion as well as dynamic changes during interventions are responsible for the complexity of these lesions. We already know what is bifurcation lesion. Bifurcation lesion is a lesion in the parent vessel very close or involving a significant side branch. What is significant side branch? Reference diameter 2 or more than 2 millimeter, significant myocardial territory, a branch that you don't want to lose. The possible locations are LAD diagonal, L6 obtuse marginal, RCA PDA, and left main coronary artery bifurcations. This slide shows the classification of bifurcation lesion. We know Medina classification is the most common classification. There are others, many classification. Medina classification is a 3-digit binary code which defines the bifurcation by presence of disease distal and proximal to the bifurcation in the main vessels and presence or absence of disease in the side branch. Definition study defines bifurcation lesion into simple and complex. A complex bifurcation lesion is defined as presence of one criteria in the first box and any two of the criteria in the second box. So points to keep in mind while doing bifurcation angle, TIMI flow in both branches, degree of calcification, uneven or ulcerated segments, concentric or eccentric location of main vessel lesions, and length of sine branch stenosis. Difficulties of bifurcation PCIs are risk of periprocedural complication, relatively high risk stenosis, complexity of the side branch, and higher risk of stent thrombosis. PCI techniques are mainly based on personal experience from skilled operators. There are different bifurcation strategy, provisional stent strategy, and two-stent strategies. Hulot, nano crash, decay crash, tap, and T are the most common two-stent strategies. So let's start our cases. Mr. X, 32-year gentleman, having positive family history, presented with chest pain on exertion for 2 months. He has history of hospitalization 3 months back and diagnosed as a case of acute abdominal inferior with acute LVF and was treated with low molecular weight heparin. He came to our hospital on 13 January for coronary angiogram. His echocardiography revealed hypokinetic mid-basal inferior and mid-inferior lateral wall, and his ejection fraction was 45 to 50%. Then we do coronary angiogram. It revealed RC is dominant and total occlusion of PLB from ostium and 60 to 70% stenosis at osteoproximal segment of PDA. LCX has 80 to 90% stenosis at proximal segment, and LAD has 90 to 95% stenosis as proximal segment and involving the diagonal. There are other views of LAD, LCX, and diagonal. So there are two bifurcations. LAD diagonal bifurcation, this is Medina 111, and PDA PLB bifurcations, this is Medina 0111. So our diagnosis is triple vessel disease. Then we calculate the syntax score. Syntax score 1 was 27, and syntax score 2 recommends CABG. We advised for CABG at the most feasible option. The patient was not willing for CABG. So we planned for PCI to LAD, LCX, and RCA. So what would be the strategy for LAD RCA bifurcation? 1 versus 2 stent strategy. We have preferred 2 stent strategy because side branch is more than 2.5 millimeter and long plaque burden more than 5 millimeter. We know true bifurcation may require 2 stent in approximately 30% of the non-left main coronary artery and up to 50% of the left main coronary artery bifurcation lesions. This slide shows the proposed approach to bifurcation lesion with drug-eluting stent by 2 stent strategy. Our case, the angle is 90 degrees, so we can do crash, mini crash, decay crash, culotte, or bis stenting. Is one technique better than others? Insufficient data for showing obvious clinical benefit of one technique over others in non-left main bifurcation. Decay crash is shown to be a better technique in left main bifurcations. This slide shows the material which are used for the procedure. Now procedure. We have first started with LCX. Left main coronary was engaged by GL7 guide catheter and LCX was crossed by the BMW wire. Predilatation was done with 2.5 to 20 millimeter balloon, and then 3 to 24 millimeter drug-eluting stent was deployed. Post-balloon dilatation was done with 3.5 to 12 millimeter balloon, and LCX is well revascularized. Now PCI to LAD. There is Medina 1-1 lesion involving LAD and diagonal 1, so we have preferred decay crash. This slide shows the different step of decay crash. Now LAD and diagonal were crossed by the BMW and CN blue wire respectively. Then predilatation of both branches were done by 2.5 to 20 millimeter balloon at 12 atmosphere. 2.5 to 24 millimeter drug-eluting stent was deployed in D1 at 12 atmosphere, and 3 to 15 millimeter balloon was kept in LAD. First crush was done with the D1 stent with 3 to 15 millimeter balloon. Then rewiring of side branch and post-dilatation D1 stent was done with 2.5 into 15 millimeter balloon. Then first case. It is a two-steps process. So first 2.5 into 15 millimeter balloon in D1 and 3 into 15 millimeter balloon was inflated in LED at 20 atmosphere individually, followed by kissing balloon and 14 atmosphere. 3 into 33 millimeter diagonal stent is placed in LED across the diagonal after pulling out the D1 wire. Then drug-eluting stent was deployed at 12 atmosphere and second crush of the D1 stent was done by LED stent. Now port was done with 3.5 into 8 millimeter balloon at 16 atmosphere and then post-dilatation of the LED stent was done by 3.5 to 12 millimeter balloon at 14 atmosphere. Rewiring of D1 by BMW wire. Second case was done with 3 into 15 millimeter balloon in both D1 LED at 20 atmosphere individually, followed by kissing balloon inflation 14 atmosphere. Report of LED stent by 4 into 8 millimeter balloon at 16 atmosphere. Then final angiogram showed LED and diagonal wire well revascular with good distal flow. So key message in these cases are wire recrossing site for decay crush technique is proximal cell or should be used routinely for all bifurcation lesion and final kissing balloon inflation important for all two stent strategies. Now PCI to RCA. This is Medina 011 bifurcation and the angle is less than 90 degree. So we have planned for bridge stent technique and there are different steps of bridge stenting. Then RC was engaged by GR 6-pin guide catheter and PLB was crossed by the CN wire with the support of caravel. Predilatation was done with 2.5 into 15 millimeter balloon and PD was crossed by the BMW wire. 2.5 into 28 millimeter drug-eluting stent was in PLB and 2.75 into 14 millimeter in PDA were deployed at 14 atmosphere sequentially. Then both stented balloon were inflated high pressure. Then post-dilatation of PD and PLB stent was done with 3 to 12 millimeter balloon at 16 atmosphere. Then kissing was done with 3 to 12 millimeter balloon at 12 atmosphere. And final angiogram showed that PD and PLB were well revascularized and good distal flow. So my take-home messages are bifurcation lesions are common and associated with increased risk of restenosis. While a provisional stent approach may be suitable in many cases, an upfront two-stent approach should be considered in patients with complex anatomy or a large myocardial area supplied by the side branch. In a two-stent technique for bifurcation lesion, decay crush technique has the potential of increasing final kissing balloon inflation, good coverage of ostium, and apposition of the stent start. Bead stenting for coronary bifurcation is useful when both vessels constituting the bifurcation are involved without much involvement proximal to the carina. I am very much grateful to my mentor, Dr. N.A. Mominuzzaman sir. You know, today is Labor Day, so happy Labor Day. Thank you so much for your patience hearing.
Thank you very much for brilliant presentation. We will take only one comment, please. If anyone's...
Thank you for showing a nice case. Actually, two lesions you have created and both lesions you have created keeping in a upfront two-stent strategy. So actually in EVC main trial, we know that there might be a single positional strategy is also a very good option. In second lesion RCA, would you consider the single positional stenting in the PLB then?
Say thought that we will do the single stent strategy, but when predilatation was done with the balloon, we found that there is 80 to 90% lesion and the PD is large vessel. So that then we will cross the lesion by the BMW and then because it is 011 Medina lesion, then we decide to do
So your first strategy
was the provisional stenting, sir.
Thank you.
Your fourth point in the take-home message, the V stenting, I'm a little bit critical about that one because that one is now, according to MATS or whatever it is, or the European EVC, it is getting obsolete. It is not that much. Why? Because you see the angulation between PD and PLB. So when you put a V stent, obviously it will miss the ostium, any of the ostium of either the side branch or the main branch, because the stent will be like this. So it's not touching the ostium. So V will never be perfect. So V is an oldish thing, and it's there in the MATS classification, but it is covered now. Because there are lots of, because at that time there was no decay crush technique, there was no other decay minicular technique, so nothing is there. So that is one thing. And another very important point I'm asking you again, whether you have put the wrong diameter or not. When you're doing a final kissing inflation in decay crush, you have put put in the side branch in diagonal 2.5 stent, right? And that means the diagonal side branch reference diameter was 2.5.
2.5.
And the main branch you have put the 3 stent or 3.5?
So 3.
3. So when you will do a final kissing, never ever take any balloon for kissing more than the reference diameter. Keep it in your mind. Why? Because the balloon up in the up, you see, you have taken a 3 balloon for diagonal and you have taken 3.5 balloon for LED for kissing, final kissing. So 3 and 3.5, the combining point over in the proximal vessel, it is in combination, you see 2/3 of that combination, that diameter is more than the LED diameter. So there will be a chance for the deformation and also sometimes dissection or many things happen. So kissing balloon means the principle is that you have to choose the distal reference diameter of both side branch for kissing balloon inflation. Never ever you should take a oversized balloon.
Thank you.
Dr. Sadur said the comment on the B stenting is obsolete. Is there any scope of B stenting still going on?
Sir,
For the younger fellows, I also informed that there is only one situation. If there is a large dialapment and there is a ACS situation like primary PCI or very critical in the LED and LCX and life-saving procedure, you can use the covering the ostium, you double barrel in the lapment. In this situation, you just bail out procedure, you can do the B stenting.
so there are some trials regarding only for left mean and in acute situations. Thank you.
তোমার মাইক ওর মাইক হয়ে গেছে টাইম আপ না এই জন্য মাইকে কথা বলতে
Thank you very much. We